He's medical doctor and he has a PhD and he has developed a system that enables data sharing, health data sharing, to develop federated learning on the huge amounts of databases. And the system has been adopted at the Canada level and is going to present it and how the things are going on and how federated learning could be developed based on this system. Jean-François, you can start if you like.
Great, thank you very much for this kind invitation, and good day to you all. As Anita mentioned, I'm Jean-François Ethier. I was very excited to talk to you because, as you'll see, it's going to be somewhat of a slightly different presentation that you might be used to the fact that we might actually discuss, or we will discuss, what comes upstream of AI learning and what our challenges, as well as what actually comes downstream, so that we can actually work together, explore how the work that's being done in Canada can be helpful to Canadian researchers, but eventually also to French researchers, because as you'll see, through the Health Data Research Network, which can be somewhat seen as the equivalent of the Health Data Hub, we are trying to generate this international web of like-minded organizations that are there to support data-intensive research. So without further ado, let's jump in within the actual presentation. And as you'll see, my point of view mixes health informatics, but also clinical care. I'm still practicing about, I don't know, 30% of a regular physician staff. And the question I always have is, why aren't we doing better? Because we have an immense research output, and yet we are facing difficult, very difficult care improvement. Now, sometimes my answer would be, well, just reboot the thing. Everything's going to work fine, especially if you're on Windows. But there's probably something else we need to be doing. And to give you an idea, if we're talking about something very simple, there's a class of medication called beta blockers. They are, at least in the 80s and to today, they're cheap, effective, and in the early 80s, we discovered that they were saving lives if you had a heart attack. Great study, published in a good journal. At that point, we could actually redo the studies and validate them. Second study, 3 years later, still saving lives with something that is cheap, already generic, very few side effects, well accepted. And it was used as a benchmark for American hospitals and saying if they were providing correct care. And this format, I'm curious to see if anyone want to raise their hands, but do you have any idea how much time it took for the health organization, so the agreement board and the states, to say, we're not using this as a marker of good care anymore because everyone's using it? So the question otherwise formulated would be, how much time did it take for a very simple care process to be widely implemented in the United States? Any guesses? I'm sure someone could give one. How much time, or the year? Assuming it started, the first study published 82.
2 years.
2 years. Do we have someone betting higher or lower? I think we have someone in the chat. So let's 10 years. We haven't got over 10 years. That's an informed guess. Actually, people don't realize that, but it's 25 years. And so during 25 years, the research had been done. We had the model, we knew what to do, and yet people died. And that keeps me up at night. And so in order to better deal with this situation, we can see that we have three kind of big, broad domains. We have care delivery that's working almost all the time with incomplete information, complete knowledge. And so this will lead to suboptimal care, as we said. And so we could be saying, well, we're going to do research to improve that. Costs a lot, difficult to recruit. Since it costs a lot and it's difficult to recruit, we almost do no validation these days. It's very, by and large, piecemeal data access. So instead of having a broad system that is predictable, helping you out, you basically ask 100 times to 100 people, cross your fingers and hope that an Excel spreadsheet will make it to your mailbox. And bottom line, there's very limited knowledge transfer. People are interested in the model and the research project, and it usually stops there. And we need to find a way that research goes further than the CV of the researcher. We need to make sure it makes it to the patient and in time, because to get people to participate in research and get them to allow us to use their data, the premise is, oh, but we're doing this to improve your care. And if we're telling them it's been 20 years I've been using your data and your health is not significantly better, this social deal will actually crumble at some point if we don't do anything. And then there's knowledge transfer. So for the times that you're actually doing knowledge transfer, it's very broad generic tools that at some point will yield what I call the enter syndrome, where the clinician will simply tap enter until the damn annoying tool goes away. And so facing this, early in the 2000s, late 2000s, the paradigm of learning health systems came up. And as you see with the orange arrow, going from research to knowledge is a very important step, and definitely there's a place for learning there. People sometimes not versed in the domain will say, oh, I got research data, so data is done. Like, yeah, well, there's slight detail in between research and knowledge. And if we position it there, as we can see, there's a big arrow coming in to be able to get research data. And there's a big arrow coming out, and we cannot forget this left arrow on the left-hand side, because if we don't, we end up with knowledge, with knowledge that is sitting in a journal. And this is, to me, totally unacceptable socially. But it goes a step further. So let's assume that instead of doing a research project, we do a learning cycle. So imagine the ethics board will say, yeah, sure, you do your research project, but upfront, you need to have an idea and you need to be resourced as to how you will get this knowledge to the clinicians. And to be honest, this is also what people may call negative results. It's crazy. I'm doing internal medicine, so as you may know, at least in Canada, we're seeing a lot of ill-defined syndromes, very low numbers. And so very few articles with large cohorts telling us what to do. And so we have choices A, B, and C. And so we're going to try B because we discussed with the patient, it seems reasonable. But then little do I know, maybe I'm the 500th person trying choice D with my patient. And every single time before it failed, but we don't report that. So I'm going to try it again. And it's a big disservice to the patient. So irrespective, we can be learning in formal research projects, but also we need to go into real world evidence. What did we try, randomized or not? And often it is better than nothing. So we need to see this as a big cycle. We got care delivery, we got research, and we got knowledge transfer here. But this actually has implications on what is required by a learning health system. So you see, the health data will go to research data, but it is very important for research data to be available for care delivery. Another anecdote, as I said, I'm still practicing, so I'm doing consultations in the emergency room, and it's a Friday afternoon, obviously, and a gentleman comes in and says, Doc, you need to treat me. I have a pulmonary embolism. So a blood clot in his lung. I'm like, well, I guess good for you, but I didn't bring my x-ray goggles, so what's going on? He says, oh, I'm part of this clinical trial where I have a CT scan, a scanner of my lungs every 3 months for prostate cancer. And this time they told me to go to the emergency room and get treated. Sure enough, I spent, and that's happening in my own center, a university center, I spent 3 hours trying to get hold of that scanner. It's Friday afternoon, it's a severe disease, and I could never do it. What happened? I had to rescan the poor gentleman. Cost, risk for his kidneys, allergies, radiation, to in the end, and time, waste of resources in the healthcare system, which these days, as we all know, is very scarce, to be told at the end, yeah, you have blood clot in your lungs and we're going to treat you. So while research data is not the same as care delivery data, and there are different protocols and all, just to say, oh, it's research data, it should be on the outside, but we're going to pump care delivery in, that doesn't work. And then if you want to do decision support and feed these tools, you're going to need the knowledge that from research and data from care delivery. So as you can see, once you start seeing it from a system point of view and you look into learning cycles, it appears very clear that there's a big gap in terms of data access and data transfer between all these partners. So let me take a step just on the side a bit. So we're getting to data. I'm going to say, what? Wait a second. It's great. So we have all these arrows now going in different directions, and this is not the way it is right now. We know it's very difficult to exchange health data right now. And so as soon as you say, oh, we're going to liberalize data access, we're going to make it much easier, then you come into social acceptability issues. You want to scale up, great. But if we keep the consent process as it is right now, project by project, it will never scale up to the numbers we need, especially not in learning. So this next track from a survey we did from Quebecers, so it's a populational survey, fairly representative, other than the fact that the population was a bit older. And as you can see, I would say the highlight, the green is good. Yes, we want. Obviously, red is we don't use our data. And as you can see, so in general, people are very happy to contribute their data for research. And it maps very much with yes, but you need to give me information. So you need to tell me you're using my research. And I need to weigh in somewhere or another through a consent-like mechanism. Now, if you give information, but you don't see consent, and there are lots of cases like this, at least in Quebec, for example, you're going to have public health that has the legal right to use an individual's data, and thank you, God, for that right now. You can see that compared to not asking and not giving information, the information, so transparency in itself improves substantially the number of people that will be in agreement with it, while it's not exactly like consent. So information is important, consent is important, or at least having a way to say it. And I would just mention it quickly here, delegation of consent. So we have this way in Canada where the health physician, so the physician in charge of the hospital could actually act as a proxy consent for many studies, for example, when they're retrospective, where there's going to be no effect on the care of people. And that, for close to 100 people, half the people, is actually unacceptable. And it's happening right now. So in some sense, I'm saying we might be sitting on a ticking bomb, because if that actually is widely publicized, there's an incident in that process, there's going to be a huge backlash and we won't be any better. So I've left the references on the slides if you want to go further. That's not the topic, the main topic of this morning, but we've worked on meta consent. The meta consent is the idea that the individuals could log in, for example, into a portal, and for groups of projects, instead of one by one, we'd be able to say how they want to give their consent. Maybe they want to give it up front and say, like green here, yes, just use my data. Maybe they want to say in yellow, something like an opt-out. So in principle, I'm happy for you to use my data, but every single time I want to be advised, and I want a period of time to finally retract for that study and say, yeah, in the end, for this one, I don't want to do it. Orange is kind of the flip of that. So it's an opt-out. I'm not completely averse to it, but unless I say, yes, don't use my data. And red is actually just upfront, forget about it. And what you can see here, we use different categories, like is it public research versus private, identifying data versus not, genomic versus not, and is the data staying in the country or not. And basically, as you can see from left down to right, depending on the characteristics of the project, the choices of the individuals vary tremendously. And this is why we are now, and there's a new law project that's been proposed early this week that enacts that. So if it goes through as a law, we're going to be able to put this in place, because sometimes you're going to hear about broad consent. Oh, we want people to give it by default, and we want to say, oh, people are happy to give us our data, so we're just going to use it, look at the survey. But people tend to realize in the survey that if they don't give their data, acceptability drops tremendously. And if you're forcing people to say yes or no, they will think of the worst. So if you give them only one option, can we use your data or not? They're going to be thinking about, oh, it's genomic data going internationally with identifying data for private companies, and they're going to say no. So I think we've demonstrated through these 3 articles that people want to be informed. They want to weigh in as to how their data can be used. They want to do that dynamically, so they want to be able to change their answers over time. And we need to be careful, because if we try to squeeze them by giving them only one choice, we might get something we're not looking for. So end of the sidetrack, but I think this is very important for people to realize that this is a significant roadblock, and that the solution to data access and learning health systems is not only going to be technical, there's a huge social impact to it. All right, what about data? Where's data? Well, we're in health, at least, I'm sure you're well aware of that, but just in case, there's a lot of information fragmentation. We have the care system from primary care to hospitals, but we also, what type of information is interesting if we want to do a learning health system? And so learn about an individual through his or her own data. If you've been genotyped in a cohort, it's almost criminal not to use it. If you've been part of a randomized controlled trial, like my anecdote, well, you're going to get more radiation if we can't use it. And I don't think the person signed up saying, I want 2 CT scan and twice the radiation. So biobank and the thousands of Excel spreadsheets that are so secure, there's also a lot in what I call quantified self. If you want to know if someone's active, like in my clinic, and say, are you active and exercising and all, usually 2 people saying, no, I'm not, and they tell the truth. And out of the 8 others, I need to guess who's saying the truth, who's lying. And if I have a watch, it's a whole lot easier to arbitrate that than trying to sort through what they're saying. Smartphones can be extremely powerful, but there are ethical concerns with all of that. And home automation to me is a biggie. So we're always talking about, when we talk about quantified self, we're thinking about sensors. And in home automation already presents a lot of sensors. So we have colleagues in Ontario working on a smart thermostat that comes with sensors. So the sensor are being used to know which room to heat, and they basically record when you pass through. So in front of it, so if you're there, they're going to heat. If it's been the Y hasn't seen any movement, it's going to stop heating that room. Now, these sensors are right now being used and to derive mobility score. And from very preliminary data, not published, not anywhere, it's very preliminary, there might be a link between the move-in score in the elderly patients and visit to the emergency room. So imagine that with a smart thermostat that's already there, you could predict when someone will go to the emergency room and potentially do something about it, trigger a visit to their primary care physician, have a social worker go in, what have you. And finally, there's everything like all the environment. I always say also, if you're diabetics, you live within and it's a Canadian thing. I know it's not, it's mostly not like that in France, but if you live in front of a fast food, the supermarket is 10 kilometers away, you need to take your car, and you have diabetes, and there's no like bike lanes and buses, you will end up having a very poor diabetic control. Irrespective, with the same pills and the same genome, it's going to be a whole lot worse. So if you really want to understand someone, you need all of this. And a quick bit on quantified self as being sci-fi, it dates from 2016. Actually, physician, patient work together, and they diagnose the patient with an arrhythmia. And so we need this data to know why and how, and was it good? Because if you want to do quality improvement, quality assurance, for example, you have access to this data. You say, great, the emergency doctor made a very good call and saved the hospitalization, both for the organization and the patient, saving money, everyone's happy. If you don't have this data, the patient should have been hospitalized if you run the analysis, and that physician might need to be suspended. And so we will need to have this, I think. And I point to yourself a ratio that I always keep in mind, not to be care-centric. If you do the ratio of the number of minutes you spend in front of a care provider versus what I call the number of minutes of real life, the time we spend with care provider is actually very limited. And so all these axes of environment, quantified self, social services are extremely important. And what that calls for is let's stop focusing on organizations and let's focus on the individual. The last weight measurement was in the emergency room. Okay, it just so happens that way, but what you're interested in is what is the last weight measurement from this individual. Now, in some cases, it might be a specific way to measure it and all, but the organization to me is ad hoc. It just happens to be where the last weight measurement was. And if we take all these sources above, right? So again, all these types of sources, genomic cohorts and EMR, electronic medical record in hospital, administrative data like NAM, and quantified stuff, Fitbits. I hold no stock in Fitbit, just to be clear. This is how it looks like. It looks like a big bowl of spaghetti, and you get 4 research projects with 4 sources. Imagine if you try to scale this up, it just fails miserably. And in fact, because all the projects will use different technology and sources will use different technology, if we're asking the sources to support every different project, it's just failing. And this is really what's happening. At some point, the EMR will say, okay, I'm going to work with the monitoring project or the management project and the audit feedback tool, but I'm just not going to support everything else because I just can't, or I don't want, or it's too much resources. In Canada, we have to compound that if we want to put a layer of law on top and politics on top of it. 10 provinces, 3 territories. And it is important to realize that health, social care, education, justice are within provincial remit. And these are the types of data that we want to be using when we model health. These are extremely important. But the provinces and territories, but mostly provinces, are extremely protective of their remit. And so in some sense, I think Canada is like the EU, with the countries being provinces and the federal government being the EU, where the federal government will institute like large policies, but the actual care and the laws and the ways to do things live clearly with the provinces, which means that if you want to use data from multiple provinces, you're going to have different systems. I think it's a richness because you can compare. But moving data across different provinces will be impossible. That's been recognized, and we'll talk about it in HRM. And just to give you an idea, it's 38 million citizens, so it's not France, but it's still a sizable chunk of individual. So I would take just a moment to say this is, in terms of data access, what comes upstream, probably the most important consequence. And I know some people might see it differently, but if you follow through and you say, I need all that was on the 5 axes, I got different countries and provinces. Now research is international. I need stuff like quantified self and data from Fitbits. It will never, ever all live in a central point. Data warehouses and data lakes definitely need to play a role have a role to play within jurisdictions, but we need to recognize that it will never all be at the same location for social reasons, technological reasons, and the likes. And so what we started with from our research group point of view and the research center is, all right, if armed with this conclusion, lots of people working in data warehousing, how can we actually work on virtual data access? Because that's what we're going to need. That's what we're going to need for social reasons, because we don't have enough patients and they're distributed across different countries. And so with that comes distributed analysis, both for learning and inferential statistics. And happy to discuss afterwards, but to me, this is an important conclusion. It will not all be at the same place. And I know it's easier if we could. I know it would be simpler, but it just will not happen. And we need to remember social acceptability, because again, if we step too far, the cookie lid will slap on our hands. In terms of distributed analysis, obviously, we don't want to end up with a model that will tell you, like Herman, that with narrow, it's a problem of gallstones. This is probably very familiar to you. It's a standard slide I put just to make sure we share the same language. When we're talking about distributed, you basically have 2 types, and it could be a mix of all. Some methods in learning will work with vertical distributions like random forest. Some others will work with horizontal distributions. So you get all the data for the observations for a single individual in one site. whereas vertical, you get all the dates of birth on one side, but the last date of last admission, for example, at hospital would be in a different source. So we're working on this. It has an impact because as of now, if you look at the literature and HRN, so the Health Data Research Network will produce a report early next year. Not all methods are amenable to horizontal, vertical, or both. And this will have a significant impact on when we allow pooling or data, or when we say, no, you should be able to do it in a distributed way. So you basically have a default, which is go with distributed analysis. So you do a local execution with shared parameters, obviously. As I said, multiple approaches. Some work in horizontal distribution, some work better or work with vertical distribution. One thing I want to highlight, because again, it's not always clear for everyone, distributed does not always equal privacy. So there are privacy preserving distributed analyses. Not all distributed analyses are privacy preserving. So if you start a very stupid thing, but if you start doing means on N of 1 and you do it often enough, then suddenly you've just extracted your entire data set. Magie. And in some cases, we think that you might have project-specific pooled analysis. So this is very important, project-specific. So it's not this idea that we're pooling all data of everyone. We're saying in a very specific situation for a project that could not be done otherwise because the data is distributed in an not amenable way to what we're trying to do, not enough patients. We need high performance, which is with the network latency not always available in a distributed way. We might want to do project-specific pooled analysis. In that case, it's important to extract only the data that is required. So you need to calculate your cohort and make sure you're extracting only the data needed only for the patients of that project, required for that project. And it's a thing like audit feedback tools, like decision support in ICU, where you might not have the luxury of dealing with the latency that would be involved. So in a more visual way, you'd have the sources, and you see now appearing parsery. We're going to get through it. It's a platform to facilitate data access. It's a big translator in terms of data, but it also is a workflow engine. So not only do you translate data, so you allow seamless communication, but you are also dealing with the workflow. So everyone knows what's going to happen, when, and how. I'd like to mention here, obviously, that all these sources for a given project could extract data to a secure location. And then you have a coordination node that will do epochs and runs on all the sites to end up with your ultimate question. There's a lot to be gained in having uniformly structured and semantics for all these nodes. So if you start with data that are conform, like structured and differently and have different semantics, it becomes very difficult, and you need to massage the data, and it's clearly not ideal because then you lose reproducibility. The other thing is we're in discussion with our colleagues at Mila and Joshua as to how we can use parsery, which delivers ontologically annotated data. So the semantic of the data is explicitly delivered when you generate your data in the secure location. And we're working as to how this could improve performance of the learning algorithms and the models developed. The idea being that right now the models spend a lot of observation trying to relearn things that are already learned. And in very large data sets, one could actually say, who cares? In a very small data set where you are at the border between requiring pooled analysis and being able to do it in a distributed way, being able to feed to the algorithms already annotated data might actually allow the algorithm to make the most of the existing observations and actually, in fact, maybe be able to avoid the pooled analysis. But if it doesn't work, so if you have low numbers or the performance is critical, parsery would also, or other systems would allow you to generate at secure location project-specific data sets. So we're not pooling everything at the same time. It's based on a given project. So to finish the data access bit, I've mentioned parsery. What is it? It's la plateforme apprenante pour la recherche en santé et services sociaux. So it's been funded by the federal and provincial government and governments in Quebec. And it's an open source approach for data access. And it's a bit of a weird beast. It is a distributed, decentralized platform. So the term I've been using now is what we're actually building is a recipe. So we're giving you the recipe, and every time you want to make a cake, you look at the recipe, take your own ingredients, and you do your cake. So when you do that, once I've sold you sold you, in this case, giving you the recipe book, if you make a cake, I don't know. I mean, it's now yours, and you use your own ingredients, and no one else needs to know that you're making a cake. Parsery is very similar in that regard. We've built a communication protocol. We've built all the different services that are needed for de-identification, safe movement of data, this translation between the local source that needs not change. I mean, we do live translations, and the questions that's coming in. So doing this translation back and forth between question data, extracted data, and in the secure location. So this is really all a recipe, and we're almost done finally the security audit for the Quebec government. So by Christmas, we should have something that is fully secure and open and available in an open source way. So what is this recipe looking to achieve? So, and it's not a cake. We want to be able to see what data is available where. If you want to know who has weight measurements, you don't want to be, we don't want people to have to know that in your database, this is how you express the weight measurement. And in this system, this is how they express it, because it's just impossible. So there's an ontological model, a knowledge model that allows you to ask questions in a very neutral way, irrespective of data models. And then the data comes back saying, yes, not the data, the information comes back that this source, and this source would have weight measurements, for example. You could look at things if the sources are enabling it, like metrics. So you'd have something like the mean, the median, and all similar information to see, I have weight measurements, but what's in there? And you see a huge average, like, okay, well, maybe it's an obese clinic, an obesity clinic. And then this is why, yes, there are weight measurements, but they're not coming from any odd system. And finally, you could actually do feasibility. So without moving data, the system is allowing you to do counts. And so play with your criteria, because the goal of Parsery is to extract minimal data, just what you need, just for the individuals needed to answer your question. So you can test your cohort, and once you're all happy with that, you can express a workflow saying this is going to be the query, data is going to be extracted there, it's going to be sent there and accepted by this person and accessible to this person. So the whole plan can be expressed and signed. So until every participant, not individuals, but organizations, entities participating in the plan have signed, nothing happens. And obviously for the participants, the system will look, if appropriate, to consent. So you could have a consent portal, and the system would only include data for those individuals that have said, yes, I want to participate to that type of project. Once it's all signed, you can automatically execute it. Data flows automatically according to the workflow, and you end up with structurally and semantically uniform extracted data set. Quickly, this is how it could be used by your teams to actually bring data to you and make it available for your algorithm. So you got a party, ENICE, which is in charge of evaluating, a bit like HAS-ish, evaluating new technologies and new medication. So maybe that ENICE is using an installation of Parsery, so instances of services somewhere in our lab, and it's saying, I need OmniMed, which is in primary care EMR, and I need CANAM data, so RAMQ, which is the equivalent of CANAM, and it's going to extract data. So OmniMed and the RAMQ will send data to a secure location where ENICE can actually go on with its analysis, whether it be statistical inferences or learning. And at the same time, you could have the Aging Research Center that would be working with two university hospitals, Quebec City and Sherbrooke, and they're using parts of the services that were used in the first instance, but it's a new recipe. So you put in the ingredient that you want when you want. So in this case, they've chosen to use different recipes with the different providers, and they're bringing the data into our secure cloud, secure servers at the research center. And you have a third one that could do similarly. for the Canadian data platform. I've been talking a lot about data access. My goal was to show you how this could be leveraged by eventually what are the challenges that you need to have in mind when trying to access data, because if it's only technology, only getting data, it's not going to work. We have approaches. If we want to do rich research, we need to cast a broad net and have a broad, in a broad sense, a broad vision from an individual, and it's doable, right? And now we need to close the loop. So I'll bring you back to the learning cycle. We're not only doing research, we're not only bringing data, we need to get knowledge out. And this is what parsery also allows you, because the same way that the primary care, so let's say that you have your cabinet ville and you have an electronic medical record and you say, yeah, I'm going to work with my patients and send them, and they're going to give data to have precision medicine tools like better diagnoses. The good thing is, the same clinic that is connected through parsery to help research can also connect a decision support tool, for example, through exactly the same system, and then have their patients and themselves benefit from being connected to parsery. And the tools that are, instead of connecting directly to a system, are connecting through parsery. So we can say with that, we're closing the loop. We're scaling up because we can actually go faster. We don't have this spaghetti bowl anymore. It's one source to the system, and it's great. Or is it so? And for the last few minutes, now we have data. We've been able to do research, and I told you it'd be before, yeah, and after. And our team is working, and our research center has a dedicated team working on all validation and implementation challenges. We know, and the date's a bit, 2019, I suspect it's a bit better, but we know that a lot of models are generated. They are very rarely externally validated, and even more rarely validated against clinicians. And when they are, sometimes they're validated using different samples, which makes it very, very difficult to decide as an organization, okay, there's this tool. Do I want to bring this in my hospital? Is it a good idea? And so at least in terms of performance, let's benchmark it. And this is one thing of an area of expertise that if you your teams are interested, we're certainly interested to open collaboration regarding that. But we need to go really further than C. We're using, you get Briar scores and you get the C score and a lot of others. And you see, this is a study we did. It's a student of mine, Ryan Tassine, that did that. We wanted to predict mortality at 1 year using structured data that was available, about free text also, that was available at time of admission. So when you made, like you stepped foot on the ward and you were hospitalized, could we calculate and predict your risk of death within a year? And as you can see, the RF is what we developed with the random forest, and it's either all the data that what we could get, or only demographic data, or only minimal. And we wanted to do that because we know it's not all hospitals that have the same breadth of data available, and especially not when patients make it to the floor. So at that very moment, because the idea was if you have a high risk of dying in the year, maybe you're going to take different health decisions. And we were benchmarking ourselves against OMER, which was a model that was developed in Toronto, Ottawa, and Boston, doing the same thing. But so what we went further with is we said, oh, we're not going to do a regression, we're going to do a random forest. And as you can see, very interesting performance, to be honest, internally, externally, and only with patients. So CDSS is clinical support systems, clinical decision support system. So people that could benefit from the intervention. And we have good performance and pretty much better across the board, even with the RF minimal, which is very minimal data set. But there's something that lies in the shadows. And it's right, we're performing. But look at what OMER was actually doing. They were basically saying in their score, if you were admitted in palliative care, you were awarded 28 points. So great, I'm going to have a model that will work superbly well, but it calls for the question of utility. If I'm being told as a physician that the patient admitted in palliative care has a high chance of dying in the next year, I'm going to say, great, but I did not need that tool. And so it's in some sense, it can be a way to pad your C statistic because you're going to be right on a lot of people. It's just not going to be useful. So there's a clear difference between utility, expected utility, and actual performance. And this is what we were trying to get at. And this has significant implications too, because if you take proxies like palliative care, and you try to run it right now when the palliative care wards have been decimated because we needed places for COVID, now suddenly the model will perform quite differently because the environment changed. So we worked, and this is the reference, we worked on calculating expected utility. And this, in this case, was our goal was to say, was there a discussion of care with the patient? Did we discuss your care might be a bit, your health situation might be a bit tricky, you're severely sick. Can you, have you thought about what you want if your heart was to stop beating, so you were dying? Should we try to get it starting again or not? That kind of situation. Not easy, but a very important one. And in this case, we had two decision trees. So in terms of the reference was in the previous slide. So if you want to look at the original method, the Vickers article is actually very interesting. So we deployed it, and we had two decision trees to decide what could happen with our model. And the idea was to see, the big difference was if the model was not triggering an alert to this certain threshold, what was happening, what were we modeling? And in one case, we said no alert, no discussion. And in the other one, we said no alert, usual care. And you see, I mean, we won't go into details here, but you can see in the articles, the full model actually performs very well. And when you look into utility and expected utility and net benefits, you have big differences between the various models. And it might push you, for example, here to say, well, I'm going to work to have this data available because if I do, the expected utility is actually much higher. So yes, C and performance, but probably more importantly is what are we achieving? What are the expected benefits? And we want to do that before thinking about deploying such a model. And I go back to the full cycle. So we've done that. So we've had data, we've had great researchers producing a great model. Seems that the expected utility is great. We're not through yet. And this is the other part of the research group. It goes with implementation, right? We have a probability of dying over a year. Is this what we're giving to the teams or the patient? What are we giving the exact percentage value? Are we giving classes? If you're high or low based on a certain threshold, how are we giving that information? Is it a message text to the patients, the physicians? Are we giving it straight to the patient, the admitting physician? Do we call in a palliative care team as a consultant to the family doctor that might have a longer relationship with the patient and might be able to better deal with this information? So even when we have something that seems to work, that is expecting to work, we have all these information, and these are things to keep in mind if we really want to have great models for learning back and have it an impact into care delivery. I know I'm running short of time, so I'll go quickly. Health Data Research Network, all the provinces of Canada, we've got $80 million over over 7 years. The goal is to foster multi-jurisdiction projects. So since all jurisdictions are quite different, both in terms of data access and the way the care is structured, we have a central hub that helps researchers navigate the various provinces. So if you have a project, you're working with the Health Data Hub and you say, hey, we'd like to have an international project, please come to us, hrn.ca. This is certainly something we're quite keen and interested to look at. A few things, HDRN itself, so the network itself does not store data, the members do. For any members, there's no obligation to participate. So if you wanted you as a source in France to participate to the Health Data Research Network, you could, and decide to only participate in given projects, and local rules fully continue to apply. The idea is to share best practices, first and foremost, have a hub to have the researchers navigate all of that, and develop tools that can be reused by the members. So parsery, so the data access platform I mentioned, It is the dorsal bone of the network. I'm calling that collaboration opportunities. Some people want to call that challenges. So the idea is very similar, and that's why parsery is being used. What's where we want to access data faster, cheaper, and in a comfortable way from different jurisdiction providers. We are a network that starts with distributed first, pooled only if need be. And so we have, as I said, a report coming up to inform the stakeholders as to what can or cannot be done according to the current state of the literature. And we want to build technological support for distributed analysis, because if we're saying you're going to do that, all of this by email, manually, it's not going to cut it. We have a strong interest, if some of you are working on this, on specific group data requirements, for example, indigenous data, where data sovereignty is a very important bit. So we're working on this. And we're also working, and this is where that might be more domain specific. So if you're working on algorithms, models to identify things like chronic diseases, and we're working on this, we have colleagues working on this, on how do you know if someone has pulmonary disease using administrative data and not clinical data, you could develop a model, and this is what they're doing. And I wanted to mention that we have an ongoing collaboration with international partners like the Health Data Hub and HDR UK. I know UK, but still they're there, and sometimes very kind and nice people. And I will finish with the Rare Disease Network, La Raison Ensemble. I have the pleasure and the immense pleasure of co-directing this with Anita, and she's representing Paris, but working in Sherbrooke. I'm representing Canada, but also working still in Sound in Paris. We have a large footprint with the patients because this network is there to facilitate the work between different partners in specific diseases across France and Canada, to make sure that these sometimes smaller teams have resources to have the patients involved, deal with social acceptability, deal with consent, and get patients to participate and use technology like Dr. Warehouse and parsery to facilitate their research, their core research. And I will mention it here. It's Anita that always mentions that, and it's extremely interesting. We're in rare diseases, but as we go towards precision medicine and we slice the pie in every smaller and smaller pieces, well, everything's going to become rare disease. So high level, parsery for data access, data warehouse to facilitate data analysis, and other tools. And we'd love to work with you on these new tools that we want to make available for the researchers. I think that's the end. So technical and social points that we need to take into account. If we take the learning health system as a whole, we can have platforms facilitating your access when doing AI to research data, good quality, uniform research data. But then we need to go the extra mile, and we need to make sure that we go with utility, expected utility. We go with the implementation challenges with the aim of improving everyone's health and not just having a flurry of papers, but no benefit for the patient. So I'm going to stop there. Last shameless plug. We have been deploying and developing quite a bit in Sherbrooke. We have an opening right now for a senior Canada chair. That's nice funding. It's millions over 5 years. And we have a CNRS lab in Sherbrooke that's been delocalized and is actually physically locally in Sherbrooke. And we're looking for not in health informatics, but we're looking to start having discussions on a similar approach for health informatics. And eventually, why not in RIA? But on a personal level, if you are interested in modeling AI or any of the topics I mentioned, like implementation, please don't hesitate to write to me. Great opportunities, great teams, great region. Thank you very much.
Thank you, Jean-François. We have time for a few questions. Are there any questions from other people? I cannot see hands raised. I have a question about the collaborations that we could implement between Canada and France about how we can access the data, because when you showed the screen on how Canadian people would like to share the data, there were differences between sharing within Canada and outside Canada. How could it be? Could you see that, for example, are there specific populations, specific kinds of people that would not like to share their data with other people to make other countries access their data? Can you see that?
Thank you. It's an excellent question, and one I should have probably dived into a bit more detail. And here in English, it's going to be, I'll try to pick the right word, but we've had a huge discussion in Quebec about data sharing, data access. Yeah. And basically what they're saying is, and this was mostly in context of international research with pharma, where the actual data could be copied outside the boundaries. And this is quite different from federated learning, where only the parameters are exchanged and eventually exchanged with external parties. And so this was the kind of objectively, like we did the focus group in a very formal way to make sure people understood meta consent. When we dived and discussed this idea of not sharing data, but the answer to the question was much more acceptable. And as you say, this is broad people. Like this was random people that were called and say, hey, do you want to participate to a survey? I suspect it will be quite different if we had only patients, and especially, for example, patients in rare diseases where they might be much more involved already.
Yeah, of course. Are there other questions? Because some people are leaving, but what you could add to your talk, because that was very clear, is the level of development, because you are going to integrate, for example, British Columbia next year and things like that, but probably you could tell us more about that.
Yes, and then there was a question from Quentin in the chat about OMOP, ODA, and Odyssey. So in terms of where we are, as I mentioned, I'm very hesitant to, people say I'm a very poor salesman, and I should be more upfront. I'm always hesitant in saying where we are, because I'm going to announce it like when we have a full deployed system and all of that. In all fairness, it's all deployed, it's with the security auditors. We're expecting the security audit stamp in Christmas. We asked for it 2 years ago, and then there was some administrative delays, and there was something called COVID, and then go figure that we're not doing security audits anymore at the health ministry. So in terms of deployment, we have the mandate to deploy for the entire primary care line in Quebec. It's a huge dark angle. Like we don't know what's happening in primary care, and in Quebec we have a very good penetration of EMR, so that's going to be covered. We have collaboration projects with Necker and Imagine, a lot of cohorts. So, for example, cardiomyopathies in the babies across the country, because there's a national network. We're going to be deploying, as you mentioned, in BC. So I'm very happy to have other collaborations. And as I said, this is fully open source. The licenses, you can do whatever you want, even if you're a private entity, so long as if you modify it, you give it back to the community. So we're really hoping to build a huge ecosystem. And to be fair, I think it's important to mention that all of this is the continuation of the Transform project, some might know, which was an FP7 project that I had the pleasure to work on with Anita. And the core ideas, the academic ideas, were actually deployed there. So I think there's a huge European lineage with parsery. If I can go back straight to the chat question. So Quentin, I'm happy to have maybe a separate chat if you're interested as to what's the difference. OMOP is a data model, and Odyssey is focusing on these only data moving around, right? That's a great system. It's a great federated system. Not everything goes into OMOP. And the thing is, it remains a data model. So it's been developed for a specific purpose. parse3 takes a step back and says, wait a second, we're not interested in the data model, and we can discuss why, because then when you start counting things, you get into trouble. We're going to define the source data as well as possible using ontologies, knowledge model. So at least you know exactly what you get. So in fact, you could use parse3 to go from sources and extract into an OMOP model. and we're going to do we're able to do the translation between the source and whatever systems they have and go into OMOP if you want. You can plug parsery on OMOP, because the thing is, if we don't go into the source data and expose it and instead go through data model, some people are using OMOP, some people are using I2B2, some people are using the descendant of EHR for CR. And so we're just kicking the ball down the road, I think. So that's why we're trying to revert to, at the very core of the data, what is it? And then you can structure it in whatever data model you're looking for. So I hope it helps, but that's a very high level. If very happy to go in further details later on if you want.
So thank you very much, Jean-François. We are going to stop this session. And thank you very much. And there is your email address on the screen, so people can ask more questions if they have in mind. So thank you again.
With great pleasure. Thank you very much for the invitation. Very happy to be here.
Okay, thank you.
Thank you. Thanks a lot.
Bye-bye.
Bye-bye.
Bye.